Robin, you talked about clinicians taking responsibility for collecting the data that they need. Can you explain what that means in practice?
I mean, we think that clinical specialists, whether they're in medicine or nursing or whatever, should take the lead in helping to design and run information systems that drive what they do. That doesn't mean to say they do it on their own. They should do it with patients, they should do it with managers, but I think they have to be pretty central to it, because unless we ensure their buy-in and their engagement, we won't get their support.
How do we marry that then with a need for standardisation to enable organisations to compare their clinical practice?
I think you can do that quite easily, really. It's about building a consensus so that clinicians look to gather the right kind of information that is of multiple value for multiple audiences. And as long as it is a standardised data set, that's fine. In terms of a national audit, that exactly does that. It's an agreed set of questions that every clinician will collect wherever you work, whether it's Chichester or Manchester. And the same should be true in relation to any kind of review process for a clinical guideline, for a nice quality standard or whatever. That they should specify a set of key measures and everybody would collect the same information.
Who should be in charge of standardising data and defining data sets?
Well, the Department of Health ultimately has the responsibility, or rather the National Commissioning Board to come. But in terms of their overall mandate, it's manifested then in terms of asking people to do it for them. And the quality standards that NICE produce are a very good example of how that's done. The National Quality Board will say we want 150 new quality standards, and then NICE are responsible for collecting a clinical group with patient interests to determine the standards and the measures that are then contained. So there is both a join of patient, professional and policy interests in putting those standards together.
You explained in your paper some of the problems that have arisen in the way that data collection in the NHS has evolved. Do you think at the moment we have too much data, not enough information and even less knowledge?
I think I'd have to agree with that analysis. There is an awful lot of information out there which is of very questionable value. Depends what we want it for, and the whole point of what I was trying to say is that information is only valuable within a process. Whether it is used for real processes and purposes of driving quality improvement and improving outcomes. And too much data, well, it's anybody's guess what it's collected for. It's process data.
What
which
changes
is
do you think we should introduce to address that problem?
We have to agree minimum data sets to be collected within routine data, which can then be subsequently used as the base for more systematic analyses. And that can only be done by that kind of consensus forming approach that I've described earlier. And it cannot be driven solely by managerial priorities, or indeed just by clinical priorities, or indeed by patient priorities, but all of those working together.
There's been a huge focus on clinical governance over the last 10 or 15 years, but you noted that many organisations still don't have an active culture of clinical audit. How could that be true?
There is clinical governance in place in most NHS trusts. The problem is it isn't often integrated in a really dynamic way into the overall integrated governance that should happen at board level. And too often clinical governance is seen as a clinical matter which is dealt with far too often just by doctors and which doesn't permeate the board's understanding of performance and effectiveness of that trust.
Is the main problem the skills of the board members in scrutinising clinical data or a willingness to tackle it?
It's a combination of all these things. Skills are one thing, in that boards typically are not clinicians and it's very easily to be baffled by the language that clinicians give you. You can also be misled by clinicians who are perhaps not giving the right kind of information. But some of it is about their unwillingness to take clinicians on and to put those kind of challenges in there. Now, I don't wish to give the impression that clinicians are looking to deceive, because they're not. The vast majority of clinicians are completely committed to improvements in quality of care. But they sometimes resent managerial interference in their clinical procedures and in their clinical governance. So it's sometimes something that they try and do, which is to keep the board out of some of those considerations, and it should be a marriage between their two interests.
Robin, you've identified a number of difficulties that beset the NHS at the moment in the way that it collects, analyses and uses information. What is your advice to the inquiry team going forward if they wanted to prevent another situation like that at Mid Staffordshire?
We certainly believe there has to be a kind of mandated set of data that every trust should be required to report, and we are some way short of that. I know that there are moves to introduce greater standardisation into things like quality accounts. We could do a great deal to kind of require trusts to report upon their compliance with quality standards, for example. And we can strengthen our requirement for them to participate and present their results from clinical audit. But the main thing that we could do to ensure that all of those things work is to ensure a reliable data portal that collects the right kind of data in the right form to be used for a variety of uses. And we are a long way away from that at the moment.
When you say it like that, it sounds like a very straightforward activity, but I can imagine it's probably a lot more complicated. Robin Burgess, thank you very much for your time.
Thank you.